Welcome everyone. Feel free to introduce yourself in the chat, say hello. Thanks for being with us here today. We'll just take a few minutes here to let everyone log in. Feel free to let us know where you are calling in or zooming in from, and what your role is in long-term care.
I'm David Brook, a medical coordinator and consultant in late life and long-term care.
Hi.
Welcome. Welcome everyone. Feel free to say hello in the chat or unmute yourself and say hello.
Hi, I'm Moranka Mordasevich. I work in long-term care.
Welcome, Moranka.
Hello, my name is Gwen. I work with the long-term care, spiritual care in Vancouver Island, the Heights at Manville.
Wonderful, welcome.
Thank you.
Hi, I'm Deb Carney and I work for Beacon Community Services. I'm the director of the long-term care.
Deb.
Yes, I'm David Clinton Baker. I'm a physician who works in two facilities, Mount St. Mary's and at Veterans Memorial Lodge here in Victoria.
Welcome, David.
I'm Ken Jolly. I'm a nurse at Mount St. Mary Hospital.
Hello, Ken. Welcome.
Hi, Jessica. Peter Horton here.
Oh,
Can
hi,
you hear me?
Peter. Yes.
Oh, yeah. Okay, good.
Welcome.
Thank you.
Hi, my name is Melissa Howarth. I'm an activity coordinator with Trillium at St. Charles Manor.
Welcome, Melissa. Thanks for being with us today. We'll just give it a few more minutes here, a few more people to join, and then we'll get started.
Hi, my name is Miriam. I work in a community Victoria Health Unit.
Welcome.
Hello.
Hello.
I'm just figuring out which plugs I should pull out.
Welcome, Dale.
Thanks, Jessica.
Hello, I'm Lori Ann, and I work at Aberdeen and Summit. I'm a registered nurse.
Nice to have you. Thanks for coming.
Hi, I'm Laura Morris. I'm a family physician out on the peninsula and see some patients in the long-term care at Sandwich Peninsula Hospital.
Wonderful. Thanks for coming.
Hey, I'm Anik Bujo. I'm an RN and I work at the Summit as well.
Welcome.
Lane Woodburn here. I work at the Heights of Mount View and the Lodge of Broadmead.
Nice to have you.
Hi, I'm Pat Gunton and I work in the Saunders Peninsula and long-term care.
Hi, Pat.
Hello, I'm Naz Merali, GP, Victoria.
Nice to have you. Great. Well, thank you, everyone. We appreciate you coming and being with us here tonight. Feel free to keep introducing yourself and letting us know where you're coming from in the chat there. We'll get started just with a brief introduction for our presenter today. So I'm Jessica, the LTCI operations lead. I'd like to take a moment to welcome you to our learning series event tonight, Dementia Behavior Complications. I'd like to start by acknowledging with great respect and appreciation that I'm speaking to you today from the traditional and ancestral territories of the Sauk Nation. I feel privileged and thankful every day to be able to live here. So a couple of housekeeping items first. Please keep yourself muted as background noise can amplify very quickly with this number of people. There are CME credits available for this event. A member of the LTCI team will email you a certificate next week for your records. At the end of the evening, we'll have an evaluation. Please take a few moments to fill this in. Your feedback is really important to us and helps shape our future events. The event will be recorded and posted on our website along with a copy of the slides and handouts from this evening. So finally, I'd like to introduce to you our presenter for this evening. We have Dr. Jane Saunders. Dr. Saunders is a geriatric psychiatrist working in the Cowichan Valley. She is the medical lead for the tertiary mental health services for Island Health and the medical director of the Cowichan Lodge Tertiary Mental Health Unit in Duncan. She has a PhD in neuropsychiatry and a master's in psychopharmacology. Without further ado, please welcome Dr. Jane Saunders.
Hi, good evening, everybody. I'm speaking to you from my office, and the challenge with that is that the camera and the screen is a little offset. So I'm sorry if I sometimes look as if I'm looking heavenwards. Sunita, have we got the slide somewhere? There we go. So thank you very much for having me this evening, and I hope that this is helpful for you. I did give a talk to this group in 2018, and I believe that it is available on YouTube and online. And I'm not repeating that same talk because a lot of feedback I got from that is that that there was quite a lot of theoretical stuff, which is a nice foundation, but that folks wanted some clinical applications. So that's my goal for today. Just to let you know, I don't have any disclosures with respect to financial sponsors. And on the next slide, I don't have any conflicts at all. We are going to be using Slido today. So this is the relevant information for you. You can either scan it or click on the link. I think that's all I need to tell you about that. Yeah. Okay. With that, let's go back and start. Okay, so Mrs. M is an 88-year-old woman that you get called to see and in long-term care. And the nursing staff report that she's hitting and biting during care, and that care is impossible. Staff are getting hurt. She's hostile and rude. And that they're requesting a PRN and a medication change. So given that, oops, there we go. Given that, my first question for you, and you can do this on the Slido, is what would you do first? Would you prescribe trazodone, 12.5 to 25 milligrams pre-care? Would you give risperidone, 0.25 milligrams twice a day and PRN? Would you ask for more information? Would you suggest the use of Posimitz during care? And would you plan to see Mrs. M the next day? So the options are, let's see what you would do first. Wow. I can go home. Oh, this is amazing. Okay, thank you. That's great. So yes, the first thing I would do would be to ask for more information. And this is so important, is that sometimes when we are faced with a situation where people are alarmed, when they're feeling afraid, that we jump in and start to do things. And quite often that lands us in more trouble than we started with. So these are the questions that I would be asking, particularly we assume that somebody's phoning me to give me an outline of the situation. And the first is to establish safety and to provide support. For the physicians here this evening, yeah, I always think about how much it takes for a colleague to phone, particularly after hours. It really does take a lot. And they do it with great reluctance. And so there may well be a situation that is unsafe. And if things are unsafe, we have to act in a different way. So to establish that is very important. The second is to ask, how long has this been going on for? And have there been any changes recently? Physical changes, symptoms of a UTI, constipation, pain, change of a room, all those various changes. Have there been any social changes? And particularly with COVID, you know, have the visitors suddenly stopped, or have visitors started and the units become quite busy? Things like that. This evening, I'm going to talk about what I call the neuropsychiatric vitals. And I use that term because these are as important to us in geriatric care as the blood pressure and pulse are in medical care. And there are three primary sources of these vitals. The first is the nursing notes. The nursing notes and talking to the nursing staff, particularly getting detailed information from those who spend the most time with the patients, often the care aides, LPNs, and the nurses on the floor, are absolutely vital. If units are lucky enough to have activity aides, rec therapists, OTs, and other staff who are working on the floors, the information is really solid gold that comes from these folks. Then we have some tools that I'm going to talk about that we use to document objectively what's happening. And I've given in the chat, I believe, copies of the DOS charting and the ABC charting, because they don't always come out very well on our slides here, and you may want to print them out. So the DOS and ABC charting in this situation show that Mrs. M has been demonstrating aggression with care for the last month. And there's been what's called a gradual increase in hostility. That's what the term is being used, and negative behaviors over the last 9 months. So if we have a look at these, there's a new DOS chart which is now used in Island Health. And for the sake of uniformity, so that we all speak the same language, we have adopted, we always use the same DOS charting. This is more complex, but it does give interesting information. And basically what you can see is down the left-hand side, the day is divided into half-hour increments. And then on the right-hand side, with color coding, you can see that the behavior is coded and collected in depending on how the person's behaving. So 1 is if they're asleep, 2 is if they're awake and calm, and 3 is if they're positively engaged in activities. And then we have vocal expressions of distress or harm, motor expressions of distress or harm, sexualized expressions of risk, verbal expressions of risk, and then physical expression of risk. So the worst one is are 7 and 8. We document per half-hour increments how people are behaving. And this particular DOS system also allows us on another page to actually quantify it. So we can look at how many half-hour increments do people spend in certain behaviors, and that enables us to recognize not only the patterns, but how people are doing over time. Now, the ABC chart, which is on the next slide, is a qualitative documentation. So just as the DOS chart is more quantitative, this is more qualitative. And here we look at the antecedent to the behavior, a description of the behavior, and the consequence of the behavior. And what is really useful here is that folks can sometimes inadvertently reinforce behavior without realizing it, and we all do that. So the antecedent might be that suddenly there were a whole lot of visitors who came onto the unit after having months of no visiting because of COVID. And the behavior might be that somebody becomes psychomotor activated and starts pushing wheelchairs around. And the consequence of that behavior may be that the person is encouraged to go into their room and have some quiet time and listen to some music, and that settled them. So it enables us to see not only what we do to try and help people, but how successful that is. And when I look at the ABC chart and the DOS chart, I always look at it with the MAR, with the medication record, because sometimes medications help and sometimes they actually make things a whole lot worse. So moving from that, we have established then that she's become increasingly resistant to care. So we need to try and figure out why. So what can cause resistance to care? So I've got here, I think we're going to have a Slido next, and I've got here some options. Poor vision and hearing, fear, pain, shame, constipation. Because I have children at university, all of the above, I think is also a possibility, and a combination of poor vision, hearing, and constipation. From having 3 university-going children at home for a year with COVID, I learned all the different variations of how they get asked questions. Okay. Yep, look at that. Excellent. Yes, all of the above. But when we come down to it, and if we look at those things, we can break that down basically into 3 primary groups of behaviors. Those that are fear-based, those that are pain-based, and those that are shame-based. So in this situation, what we saw was that on the DOS charting, there was just a question that popped up about the DOS charting. On the DOS charting with this, we saw that the behavior was centered around care. And so she's hitting out, she's biting, and so on during care. And so that tells us that it's one of these 3 things that's going on. So fear during care arises when a negative association between care and a feeling state occurs, and people feel vigilant, and they feel as if they have to defend themselves. And it results as a consequence of poor information processing and sensory impairment. If we think about people as they age, auditory problems usually predate visual problems in terms of the number of patients who are completely deaf versus blind. But most of our patients have poor vision and to some extent some auditory problems as well. And we also know that visual fields diminish with age, that people have poor visuospatial abilities. And then add to this, if they're moving around, they don't know where their bodies are in space, and suddenly they put in a sling, or suddenly they're being turned. They may have postural hypotension. So if they're suddenly told to sit up, they may feel dizzy. And they may have a negative association either through previous traumatic events or through pain. So if people have pain during care, this leads to fear, because all of us want to avoid pain. So pain is very, very common as we age. And one of the challenges here is that it is under-recognized and undertreated. And it always astonishes me how much pain we expect elderly people to tolerate. You know, if you go into a hospital after someone's had hip surgery or, you know, they've broken their wrist, because many of our folks can't articulate that they have pain, they simply don't get appropriate analgesia. So osteoarthritis, GERD, patients who don't want to lie down for care because they get reflux and it's very uncomfortable, people who have pain related to having a malignancy, people who get dyspnea and short of breath, so lying down becomes terrifying, people who have bowel care and may have had a suppository or even an enema, and then subsequently they are passing painful stool, and so cleaning the perianal area is very painful. And then for many of our elderly female patients who have atrophic vaginitis, which can be very uncomfortable, they may have recurrent yeast infections, they may have recurrent urinary tract infections. So there are a whole host of reasons why people have pain. Some of it really can be awful, particularly when we see patients who have spinal stenosis together with arthritis and perhaps a malignancy, and then care becomes extremely painful. Okay, the other thing we need to talk about is shame. Particularly for patients who are in our generation of our elders and seniors, nudity and modesty may be very important to people. Remember that people may have had a previous experience of sexual abuse or other forms of abuse. They may be survivors. And so suddenly not understanding why somebody's approaching them to remove their clothing, to undo their belts, to suddenly feel a cold or even warm cloth around their genital area can be extremely traumatic for them. People can also feel just ashamed because they have a sense that they should be able to do this. Having somebody else cleaning you can result in shame in any of us, and people often feel humiliated. So it's usually a combination of these three factors that result in resistance to care, and a negative loop then develops where people associate and anticipate that the care is going to be uncomfortable and fearful. They then try and defend themselves as best they can. That defense often takes the form of verbal outbursts or physical aggression, because that is all that the person has left in their repertoire. They can't understand exactly what's happening, and they can't articulate it clearly, and they're in a fight or flight situation. So in this particular situation, we wanted to gather information. We wanted to get the neuropsychiatric vitals, and we wanted to identify and address potential causes. Though that's the order in which we want to address the situation. If the person's behavior when a nurse phones is putting patients at risk, we go into a completely different algorithm if they're acutely behaviorally disturbed and they're having what we call a behavioral emergency. And I'll talk a little bit about that later. But for this particular case, we're presuming that things are challenging. Staff have had some minor injuries. Some staff are frightened of approaching Mrs. M, and so we can take our time. So given that Mrs. M, we discover, has constipation, she's day 8. She has severe pain from, we can look at the next slide. She has severe pain from a combination of OA and spinal stenosis. She's always been extremely modest. Nobody was ever allowed to see her in her underwear, let alone with nothing on. And she's very afraid of the care. She doesn't understand what people are asking her to do. And she's combative. It looks like she's trying to fend off people. So given those things, what would you address first? Okay, a bit more of a spread here, and this is interesting. So, yes, I can see why people would think those things. So the question is, what is the order of things? What should we do here and why? So for those of you who thought that we should do everything all at once, that is the correct answer, but it's an exception. Because by and large, in geriatric care, we like to do one thing at a time. Because if we address one thing at a time, then we can work out whether a temporal relationship, a relationship in time between an event and a behavior, is in fact a causal relationship. In other words, that that particular event or problem is causing that behavior, and equally that that intervention that we're using is causing the results that we're seeing. And this is particularly so with medications. We really want to do this with medications. And unless, again, we're in an emergency situation or by exception, we do one thing at a time with medication. Because if we don't, we could land up a creek without a paddle. We don't know which way we're going. We don't know which is cause and effect. But if we look at the next slide, in this situation, there are things that must be addressed, and they're not going to conflate into side effects or other challenges. And I apologize for the 2 H's on the patch. I've just seen it here on the screen. So yes, we can address a number of these things simultaneously because many of them are non-pharmacological. So let's look at them, and starting with the constipation. Our favorite intervention for constipation, apart from prunes, which you can't get at all facilities now, is PEG. And polyethylene glycol, which we see in Restorelax or in Laxaday. And it is apparently the preservative or component of, I believe it's the Pfizer vaccine as well. The reason that this is recommended as best practice and first line is because it's very well tolerated and you don't have to drink a lot of fluid in order to get benefit, as opposed to Metamucil. Metamucil is fine if people are taking adequate fluid, but if they're not, then their constipation can turn to concrete, can be very, very painful. The other thing is about PEG is that it tends to cause the least in terms of stomach cramping and discomfort, as opposed to lactulose and the Senas, which can cause quite a lot of cramping. But most places have a bowel care protocol, but we would start with a PEG, often 17 grams a day. Yes, somebody made the comment about slow colonic transit and the contraindication for Metamucil. And it's the same thing, is that basically you end up with concrete. So we don't use Metamucil, but I think it's still used quite a lot in primary care, I believe. it is amazing how often I see patients who are not just day 2 or 3, but they are day 7 or 8. And it is really concerning. I see someone's just put up a note to say that in some of the long-term care facilities, they've stopped PEG because I couldn't see the end of why. Was it because it takes too much time, or? But that would be very disappointing. It's the same reason with prunes, which is such a simple thing to do. But really, it is quite astonishing how people don't seem to understand how much discomfort and fear can arise from not passing stool for 4 or 5 days. Recently at Cowichan District, I had a patient who had not passed stool for 9 days. And then dealing with that problem can cause enormous pain. Spinal stenosis and osteoarthritis, we often see this in combination. And again, I was mentioning before about how severe pain is often underdiagnosed and undertreated. Martha Donnelly wrote a very nice article in our local BC journal a few years ago about an approach to pain in elderly patients. Some highlights from that article include how concerning it is with respect to renal function and deteriorating renal function with respect to non-steroidal anti-inflammatories. So we tend to avoid those. Tylenol is the gold standard in the beginning, and the golden rule, of course, is we don't want to play catch up with pain. We want to get ahead of pain, and then the requirements for analgesia are reduced. We also want to address the frequency of the use of Tylenol. I quite often see somebody gets it just at night. And then again, we're playing catch up. If we need to move to something more than Tylenol, and it's possible financially because this is expensive, the buprenorphine patch is well tolerated even in opioid naive patients, and it comes in 5 and 10 milligram doses, but you can put a little bit of Opsite or something underneath it and even get a lower dose. We do expect, of course, the usual side effects of worsening constipation, and people can be quite sleepy for a few days, but it certainly can be extremely helpful for some people. With pain, non-pharmacological strategies are often forgotten. So having an occupational therapist do an assessment in terms of if somebody's in a chair or other aspects of the mobility can make a huge difference to pain. And then simple things like using heat, helping people to change their position, basic nursing can also make a big difference. For modesty, some of the strategies which can be very helpful, first of all, including the person in their care. So handing them a cloth, using a modesty apron. So a modesty apron is simply a usually elasticized apron that has some Velcro at the back that you can put over somebody's genital area. It usually ties around the waist, and so that they feel covered for the vast majority of their care, and then normalize the person's experience. So I think we've probably all had that experience of walking into a room where somebody's getting care and the people administering the care are chatting to each other, you know, about Justin Bieber or, you know, the news or something, and the person's not included in the process at all, and they're being spoken over, that there's lots of noise and the stimulation level is much too high. So having one person making eye contact, speaking in short sentences, using humor, depending on a person's cognitive ability, and being aware of which person that on that particular shift that resident has the best rapport with, and then dividing up roles if possible. Now, I know that sometimes it's not possible, and at the moment, people are so short-staffed, you often just have to make do. But even within that moment, if there are two people giving care, one person may, for some reason, have better rapport with the client than someone else, and then use that to your advantage. Okay, if we're going to talk about fear, fear is that negative association that we have often with pain or some other negative event that I mentioned earlier. And what happens then is that people are anticipating harm. So that's why there's resistance to care, is because they're anticipating that they will come to harm. And they're doing the best that they can to defend themselves. A question just came up about pain and the use of Suboxone. We are using methadone in some of our patients, and for people who can't afford it, we are tending still to use fentanyl. But then we have to go through that process of giving the dilaudid first, the hydromorph first. Hydromorph and hydromorph related derivatives are definitely safer than some of the other possibilities. So if we go back to fear, one of the things we want to do is to form a positive association and to facilitate a positive association with care. And this is the concept of non-care contact. So what we mean by that is that if a patient is highly resistant to care, all their care experiences are going to be negative. They're going to be fighting for their lives. The staff are going to be having to hold them down because there's stool perhaps dripping down their legs. The staff are frightened, understandably, because they're getting hurt. The resident is frightened. And so both the staff and the resident anticipate that this is going to be a tough situation. And then when the care takes a long time and it's combative, staff understandably don't want to go back into that room, and those folks tend to then become isolated and marginalized within the care community. So one of the things that can be very helpful is non-care contact. And at the moment, because folks are so short-staffed, this can be a huge challenge, but it can be as simple as setting up the room in the same way as if you were going to do care, and then just coming in and giving the resident their favorite food, their favorite treat, like chocolate. And would you like some chocolate, Mrs. M? And chatting to her, and then leaving. So what she's doing is forming a positive association with the contact with the care staff, with the human contact, and you just build on that, so that there's a separation between the person who's giving you the care and that fear. That's what we're trying to do. We're trying to break that cycle. So if you come to Couch and Lodge, to our tertiary unit here, during care, you will find an unusual array of strategies. We use those big cups that people have water in, and we put cheesies in them. We fill the cups with cheesies, because cheesies are, if you've ever had a cheesie, they're sort of made of nothing. They dissolve in your mouth. And the consequence of that is that they're not a big choking hazard. And so we can give them to the vast majority of our residents, and most of them love it. So what they do then is they get given the cup. Doesn't matter if they throw the cup of cheesies at us, because they're just feathers. They don't really, they can't really hurt anyone. And they hold the cup, and then they're busy taking the cheesies out of the cup during care. So what they've done is formed this positive association with care, because they get cheesies. Other patients get chocolate. We've got one younger patient on our unit at the moment who's particularly frightened during care, and he's from the boomer generation, and so we have he likes to have care to rock and roll and even some heavy metal music, which is new in my field, I must say. You know, we're moving away from Frank Sinatra. And so it's really about meeting the person where they are and using the person-centered principles. And those are the principles that I talked a lot about in my previous talk. And so as you can see, the better we know the person, the better the care that we can give. So that principle of non-contact care is very helpful. Okay, next slide. So when we understand, to try and understand aggression, what we want to understand is why are people with dementia aggressive? And what we often hear people say is that the patients are being predatory, that they're being, it's premeditated. And really, if somebody has a MOCA of 4 out of 30, this isn't possible. It's not possible for them to formulate that degree of cognitive sophistication. And this can be very challenging because it can feel very premeditated, because it sometimes is targeted. And it's targeted because patients are cued by their environment. And sometimes we have some bizarre situations that cue them. For example, the color of somebody's eyes may remind them of someone. We had a patient who would hit out every time a staff member who had very bright blue eyes was administering care. And it turns out that he had had a negative interaction with an adult repeatedly as a child, and this person had very piercing blue eyes. So sometimes we can't figure out exactly what's happening and what the motivation is, but there's some things which can help us to address the situation. Now, a very useful concept is a concept called theory of mind, which comes from originally the autism spectrum literature. And that is the idea that we have the ability to empathize with others and to understand that other people have needs, and other people's need to be considered. We need to have consideration for others. So this idea that if somebody's busy and I ask for something and they say, I'll be with you in a minute, that we understand that that person might be busy. But as Teepa Snow, who's one of my favorites, who's a world expert in non-pharmacological strategies in dementia care, says, the vast majority of people with dementia will say, I want it when I want it, when I want it now. There isn't that ability to delay gratification. And part of the reason for that is because people have lost theory of mind. They've lost the ability to understand that the needs of the staff are also important. They don't understand that the staff might be frightened. They're only able to understand their own emotional experience. And they understand that on a very experiential level rather than being able to take a step back and have perspective. A useful way to conceptualize this can be to use the theory of retrogenesis. And retrogenesis is the idea that sometimes we lose skills that we've gained through childhood. We lose as we develop dementia. And so the caution here is when we use this approach is not to infantilize our adult patients with dementia, but it can help us understand, if we think of the behavior of a small child who's unable to delay gratification, and they're not deliberately making their parents' lives miserable, they're trying to get their needs met, but they have limited tools to do so. Then, of course, we all respond in different ways to fearful situations. And Teepa Snow, in one of her courses, gets the participants to do this exercise. And what she does is you sit with your eyes closed and your hands on your lap, and then you don't know it, but someone's going to come and poke you in the ribs. And when the people I was training with did that to me, I automatically hit out like this. It was a reflex. Other people crouched in and tried to get away, and other people froze. So I'm afraid I'm one of the combative ones, was that my reflex to that physical poking was to hit out. Now, my reflex to a verbal insult may be to freeze. It may be completely different. We have different emergency responses to different situations, but it's a very natural response to swat out if we feel threatened. In looking at aggression, even though we often use medications when the aggression becomes extreme, using these non-pharmacological strategies and trying to understand what people are trying to communicate with us when they're aggressive is always where we start. Okay. Right. So I could stop there and we can have some questions, or I could continue the story. The clinical scenario does continue, and I don't know what folks want and would find more helpful. This is a bit difficult because I can't see anybody's faces. I'm sort of talking into a vacuum.
I'd like to continue. I'm going to make a comment.
Sure.
It's Dale Nickel. I'm the medical director at the Lodge of Broadview. I'm sorry for barging in earlier. I didn't realize that you were asking for comments or introductions. In any event, I think that if people, if caregivers walk into a person's room and start rifling through their closets looking for clothing for the day and treating them without any respect, that's going to lead to hostility as well. And I remember a number of years ago when I brought that up with some of the staff members, I was thought to be a little bit daft because they thought they were treating everybody with respect, but there was a lot of improvements that needed to be made, and that did make a difference in the care of people. I mean, all of our residents have histories, they have lives, and they've been accustomed to being treated like in a certain manner. And I think we should try to adhere to that as best we can. And of course, supply affection along with the respect as well.
Yes, absolutely. And if the story continues, I can weave some of that into it in terms of the person-centeredness. So would folks like me to continue a little bit?
That seems to be the consensus in the chat.
Okay.
They'd like you to continue. Yep.
Okay. I can't see the chat, so great. Okay. Okay. So with our Mrs. M, there's improvement with the strategy. With those basic things, there's some improvement. We've addressed her constipation. We added a buprenorphine patch, which was very helpful. Care was much improved. Now, for the physician colleagues, at the end, we can talk about some of the other PRNs that we give for care resistance. But for the sake of this discussion, I'll leave it for the moment. There's quite a lot that we could talk about if you want to. So when we go back to the original description, we had two essential problems. We had the problem during care and addressing her constipation, her modesty, using a modesty apron, and addressing her pain really seems to have helped that. But there was this irritability and hostility that was being described. So Mrs. M is being described as continuing to be intrusive, particularly after about 4 in the afternoon. She won't sit to eat. She's hostile and irritable. And she started to develop some psychotic symptoms. She says she has no clothes. She says that part of her insides are rotting. When the staff want to get her up in the morning, she doesn't resist care, but she says there's no point in getting up because she hasn't got any clothes. She'll be naked all day. That she's dying. There are bits in her body that are rotting, her stomach's rotting, and her heart's starting to rot. Okay, so let's move to the next slide. Her current medications, she's on Tylenol 3 times a day, She's on her buprenorphine patch. She's taking some amlodipine for her blood pressure. And she has had since childhood some mild asthma. So she's on some Advair and PRN Ventolin. And then to help with sleep initiation at night, she takes trazodone 25 milligrams, which she tolerates well, and it really helps her get to sleep. So she's not on a lot of medication. So what do you think's going on? Is she delirious? Is she sundowning? Does she have depression? Or does she have akathisia? What do people think? Okay. Excellent. It is tricky because she has elements of a number of these things. Let's go to the next slide. The first thing we need to do is to get collateral. And this is where you were talking earlier about the example of going in and rummaging in somebody's closet. This is where it becomes so important to get to know this person. So we go back to the DOS charting to see whether there are patterns in her day, what she's doing, what is she articulating. We may use the ABC charting for that. But the principle is the better we know our patients, the better the care we give them. We want to know questions about who was this person in her prime? What were her values? What were her likes and dislikes? Was she an introvert or an extrovert? And this may sound like a silly thing to be interested in, but it's something I'm very interested in, and I learned this from Teepa Snow. That if you think about being an introvert and going into care, or being an extrovert and going into care, you can see that the challenges and the benefits will be different. So we can look at lots of ways of trying to determine whether we're introvert or extrovert, but it really comes down to one thing, and that is, how do we self-soothe? Introverts self-soothe by taking a step back and having quiet. Extroverts self-soothe by having social interactions. That's what fills them up, as opposed to an introvert who really wants to spend some time in quiet, and particularly if they've been exposed to a lot of stimulation, they want to have some quiet. And what we use up in the Cowichan Valley in our long-term care and tertiary units is the My Story. But there are a number of versions of this, and our colleagues in recreational therapy, incidentally, I worship recreational therapists. I wish we could clone them. But they have various ones that they use that tend to be more sophisticated and detailed. But the My Story essentially is a short biography of this person, of who this person is in the world. And that will give us an enormous amount of information. That enables us to be person-centered, and that enables us to get behind the behavior to the meaning of what people are trying to communicate. Okay, so let's see this for Mrs. M. The further collateral tells us that she is a retired librarian, loved reading, loved books, and loved quiet. She was an introvert. She was diagnosed with Alzheimer's disease about 8 years ago. So she's moderately far along on her journey. She was always very gentle and kind, and she had a very good sense of humor. Her family were her life. And she had an episode of depression. She had one previous episode of depression. And that was when she was newly diagnosed with Alzheimer's disease. She had insight and realized what was happening. She'd had a family member who'd had Alzheimer's disease and friends who'd had it. And she became profoundly depressed, but responded very well, and her depression resolved. She hasn't had any visitors for a year because of COVID. Even when the restrictions lifted, her family lives in the US and hasn't been able to visit. Okay, let's go to the next slide. So in fact, Mrs. M has depression. Now, the differential diagnosis was she delirious? And that was a good thought. What helped us to exclude that was that this has been going on for months. This was already a problem which had been highlighted when she was first referred, and that she doesn't have the other features of delirium, like day-night reversal, and so on. Remember that psychotic symptoms, particularly nihilistic delusions, are very common in late onset depression. So the kind of psychotic symptoms she had are fairly classic of depression. Sundowning is a phenomenon which tends to be linked to people who become overstimulated towards the end of the day. And certainly there could be an element of that for her. But the predominant problem is that of depression. I'm pleased that people thought of akathisia because it's such a big problem, but she's not on an antipsychotic, and that kind of dose of trazodone is very unlikely to cause akathisia. Of the antidepressants, trazodone is an antidepressant in essence. Of the antidepressants, the one that most commonly causes akathisia is fluoxetine. And that's why it can cause such agitation. Now, someone's got their hand up, and I don't know. Someone got their hand up? Question? No, okay. So depression is very common. If we look at the literature, it varies from about 40 to 80% of people in care will have depression. And I don't know if you folks have found the same, but we found that COVID-related isolation has had a profound impact on our seniors, particularly our seniors in care. And that seniors will say to me, you know, nobody has hugged me in a year. Nobody has touched me except to help me with care in a year. The staff are understandably trying to address infection control, where they're all wearing masks. Although I've been amazed how our demented patients have managed to adjust to the masks. But remember that the sensory system that is best preserved, even in dementia, is the visual system. And so they're losing out on all those nonverbal cues that they're depending on. So it's a huge challenge for them. And the lack of visitors, and not just family visiting, but volunteers, companions, having outings, social engagements has had a profound impact. So one would think that does Mrs. M automatically need an antipsychotic? And the answer is no, not in seniors with depression. It depends on a number of factors. If she's acutely suicidal, then she may need an antipsychotic if her psychotic symptoms are driving that suicidality, and if she has the ability to act on those impulses. But she certainly needs pharmacological treatment. But even in the face of this severe depression that she's having, and I'll talk a little bit about the pharmacology, even in the face of that, the primary intervention are for non-pharmacological options. And seniors with depression often respond very well to the non-pharmacological options. Given the severity of her depression, a combination of non-pharmacological and pharmacological options would be optimal. So what are those non-pharmacological options given the limitations because of COVID? Well, the use of technology, and I think most long-term care facilities and units for seniors are using Zoom or FaceTime for our seniors to try and have some communication with their family members. And again, I'm amazed at even people with profound dementia, if the screen is big enough and it's put right in front of them, can get some joy from it, even if it's just for a short period. The other thing that can be helpful is for loved ones to make recordings of their voices, reading favorite stories, recounting family stories and myths, and talking about their childhood, singing to their loved ones, singing over FaceTime, and the use of transitional objects. So a transitional object essentially is an object, it can be anything from a stuffy to a picture to a rock, could be anything, that represents a relationship in our lives. And we know that small children use transitional objects all the time. They'll have a blankie or something like that, or teddy bear, and they can be a source of great comfort. So the transitional objects that seniors use sometimes also serve a meaningful activity for them, such as having a robotic dog or cat, or a doll, or there may be something such as a laminated photograph of a loved one, or a favorite shawl, or a favorite throw on their blanket, on their bed. Those can be very helpful. But in this situation, pharmacological treatment would be important, and so we would choose an SSRI as first line. Okay, we can go to the next one. So the question is, what investigations? This is for those who are doing prescribing. What investigations need to be done before prescribing an SSRI in this context? Is it an ECG? Is it renal function? Sodium? Nothing? Do we need to do anything at all? ECG and renal function. I don't know if there's a last one. I can't see it with my computer. Okay, we can just stay with this slide. And this is a very interesting slide because oopsie, Sally hears something. And this is a very interesting slide because it demonstrates some of the debate that we have in terms of how much should we investigate elderly people and the quandary that we're often in. So sometimes we think, you know, should we do an ECG? Should we take labs? And some of it will depend on how well that's tolerated by the person and how distressing it is. If you have somebody who's an M1 and who is very frail, and we don't anticipate that they're going to live more than a few months, that may change one's recommendations to family. And of course, ultimately, the substitute decision maker has a huge role to play in making these decisions. Okay, let's next go to the next slide. So before prescribing an SSRI, given that Mrs. M is still I mean, she's certainly not palliative. I would argue for doing these investigations if possible. Not that we're trying to do anything fancy to prolong Mrs. M's life, but that these are quality of life issues. So with the ECG, we're looking at the QT-QTC interval, particularly if we start layering on medications such as an SSRI and then an antipsychotic if we needed to add that. It's nice to have a baseline to see where we're, what the person's capacity is with respect to this. Citalopram and escitalopram can both prolong the QT a little bit. Citalopram more than escitalopram. They're our first line in other respects because they're so well tolerated, and they are the most purely serotonergic of our drugs. Escitalopram is the most purely serotonergic, and then citalopram. But because of QT prolongation, we like to get a baseline there. The reason we want to monitor the sodium is because SIADH is a common problem in the elderly, even without sorry, I was just looking at the chat there, even without adding an SSRI, but many medications we use can deplete sodium. And hyponatremia leads to lethargy, fatigue, and poor quality of life. So even if you think, well, you know, we wouldn't do much about it, we actually would, because it's a huge quality of life issue. Renal function is important because we will do dose adjustments. And that's why we want to know what the renal function is. We don't want people to become toxic. So if we can't use escitalopram or citalopram, or we're concerned about the QT and we can't do an ECG because the person won't tolerate it, then sertraline is a good option. Sertraline of the SSRIs is least likely to affect the QT-QTC. It's well tolerated. It does tend to have more GIT side effects, and it does act on other neurotransmitters other than serotonin, although it's predominantly an SSRI. Okay. So if we want to look at Mrs. M's quality of life and say, well, what is the point of treating her depression? Actually, we can make a big difference to her quality of life. She will improve with these interventions. And some of the other things that the staff noted was that her room was really close to the nursing station. And the care aides and activity staff suggested that we move her down to a quieter area. And this was so helpful for her. She didn't get overstimulated by the noise, but in conjunction with that, volunteers were being allowed back into the unit. And once they were allowed back, a companion comes to visit her 3 times a week and reads to her and reminisces with tools that the family have provided quietly in her room. And she loves that. And the staff have also started going into her room and just popping in for 5 minutes here and there and offering her some of her treats that she likes. And there's been virtual resolution of symptoms. So for Mrs. M, the combination of treating those issues, the fear, the pain, and the shame around her care, and then using a person-centered approach to make the diagnosis of depression, and using a combination of non-pharmacological and pharmacological approaches really helped her. And she's gone from being one of the people who the care staff were the most afraid of and avoided to one of their favorites. And she's even started to demonstrate some humor. There was a small window where her one family member was able to come and visit. And hopefully that's going to improve and will make a big difference for her. So just just in before I conclude, I just wanted to chat a little bit about what antipsychotics are helpful, and they're helpful for delirium with agitation and psychosis. They helpful, obviously, for overt psychotic symptoms, including pre-existing disorders like people like schizoaffective disorder or schizophrenia. They, in the behavioral realm of dementia-related complications, for aggression and psychomotor agitation, they can be helpful, but be very careful of side effects. We have included in the chat the best practice guidelines for the treatment of behavioral and psychological symptoms of dementia that Carol Ward's group brought out. It's specific for BC. It's a fantastic document, and it gives you the doses of the antipsychotics and some more details around that. So I strongly recommend that if you are a prescriber, that you use that to refer to. Okay, the last slide. In essence, what I'm trying to say is that the person matters. I have a background in neuropsychiatry and in psychopharmacology, and yet it is the person who matters, much more so than all the neuropsychiatric stuff. And we need to be curious and to be detectives. Teepa Snow talks about who has the intact brain. And in my talk from 2018, I talk quite a lot about that. We're the ones with the intact brains. We're the ones who need to use our brains to try and find out what's happening for this patient. And we can make a big difference to the quality of people's lives. We are walking beside folks at a time in their journey where it's not the quantity of time that they have left that is most important to them and their families by and large. It's the quality of that time. And through interventions such as the ones that I've described this evening, we can really make a big difference. It's incredibly rewarding work. So I welcome any questions or comments, anything anyone wants to chat about. There was something that came up in the chat. Its title is the Best Practice Guideline for Accommodating and Managing Behavioral and Psychological Symptoms of Dementia in Residential Care, a Person-Centered Interdisciplinary Approach. I had to read it because it's quite lengthy. And even though it's from 2012, it's a very, very good document. It's available online. And it's also, Sunita has shared it, I believe, in the chat. And we've also shared the DOS chart, DOS tool charting, and the ABC charting. So Jane asks, where does the information in my story live on our units? It's not always easy to find. Yes, that's a good question. So it depends. On our tertiary unit, we have a sort of one-pager that is sort of compulsory reading. So even if we have a casual who comes on, we really require that that person reads about the residents that they're going to be caring for, the absolute do's and don'ts. But then we have a care plan which sits on each care station. So it's not in the medical information. It's together with the whatever the nurses use most frequently. The other thing we do at Couch and Lodge is that we have very active care planning built into our ward rounds and our meetings. So that's a huge part of what I do and what our team does. And we have a fantastic team here. When I go to care facilities with our GSS team colleagues, what we try and do is is tease out those essential things. And the first thing I will say to the staff is, have you done a My Story? Or what do you know about Mrs. X or Mrs., and so we try and encourage people to get those essential pieces of information. One thing that I really love is, and I don't know if you have it at some of your facilities down in Victoria, but some of ours have it, is it's a little box outside people's rooms where you can put some trinkets or photographs and a little biography of that person behind some plexiglass. Oh, someone's reminded me about pieces. Yes, I talk about pieces in the other talk. Yeah. Pieces approach is excellent. So having that, so that when you walk into a person's room, you have an image of who this person was in their prime. And that makes it easier for the staff to relate to who this person was, and it provides talking points. One of the things we also use, and including when people are in hospital, is to have photographs. People take photocopies of favorite photographs, laminate it, and then put on the back a little story for the nurses. So let's say that Mrs. M gets admitted because she fractures her hip and she's unsettled and she's in pain and we're trying to help her. They can pop in and see her, just turn one of them over and they have a little talking point. And so they can use that in long-term care, but also when people are frightened in acute care. Any other questions? Just a little word about Pieces. Pieces came out of Ontario and it's been rolled out across BC. It is a for-profit approach that is used in dementia care, and it's particularly used diagnostically. It's very thorough. I do quite a lot of lecturing in the Pieces program, particularly around the pharmacology, and it's a fantastic resource. But unfortunately, it is for profit, so it's expensive. The license, I think Carol Ward mentioned that the license cost her $90,000 a year, I believe. So what I'm trying to do with these talks and chatting to folks is to take some of those essential sort of things out of all these different things, because there's so many private ones around. One that's fantastic for care aides is GPA, Gentle Persuasive Approach. It's a really great program, and that's once a day. I've done that one with our care aides and nurses and our team. We did it together. For the physicians who are here, colleagues of mine in Victoria, Dr. Kuram, is working with nursing colleagues to develop a midazolam algorithm for people who have extreme aggression and fear during care. And this is because midazolam is increasingly being used. And of course, there's some concerns naturally because it's such a potent short-acting benzodiazepine. But that is in the works at the moment. They're looking at the evidence and trying to develop something so that it can be done as safely as possible with consultation from expert pharmacists and so on. Okay, everybody's ready to go home.
Yeah, if anyone has any questions, please feel free to unmute yourself and ask away. Now's the time.
That was really helpful. Thank you so much.
Oh, it's a pleasure. Thank you. It's the first time that I've given such a big presentation with COVID, and the not being able to interact with the audience it's tricky. So I'm glad it was helpful.
It's Dale Nickel again. One of my favorite lines that you delivered in 2018 when the nursing staff called you with behavioral issues was, "Why are you calling me? All I have is a prescription pad."
Thank you for that.
That was
great
Sorry.
presentation. One of the best I've heard in the last 2 or 3 years.
Oh, thanks,
Jen. I just have a question about Dr. Curran, the work he's doing on the algorithm. Do you know how that's going to be shared? Like because I don't need to miss on it because I use it a lot.
Yeah, I believe that because he works at 2 Southwest, the tertiary unit at Royal Dube. So we are starting off at those 2 here at Cowichan and at Cowichan Lodge and Royal Jubilee. Our teams are working together because we have these very high acuity folks. And then I think they're planning to roll it out. I believe it's used quite a lot at GTCU as well sometimes. I may be wrong. Or is it the summit? I think it's going to be rolled out. The plan is for it to be available for everybody in Island Health, yeah. But I believe the first meeting started about 6 weeks ago. I think we had our first discussion, and he's leading it. I'm not actively involved with it. So hopefully that'll be coming out soon. I've learned an enormous amount about the use of midazolam from our physician who works with us here at Cowichan Lodge, who is a family doctor, but she does a lot of palliative care. And it can be transformative for very specific exceptional patients.
Do you have any comments about the use of props, visual props? And by that I mean the doctor's bag, the nurse's cap, in terms of helping people who are at sea to understand who is approaching them?
Yeah, that's an excellent question. We use props all the time. And I think I may have mentioned in my talk last time, you know, I've even done appendicectomies on stuffies because I've had nurses who believed that their stuffy had appendicitis. And after I did the appendicectomy, I put the little bit of stuffing in a little urine bottle, and we put it next to the person's bed. She was absolutely delighted. End of problem. So we do use those. I also had a group of guys who were in our tertiary unit together. There were about 3 or 4 of them, and they kept asking to speak to the shop steward. They were absolutely irate, and they were stirring each other up, and they were trying to climb out of the building and so on. And we got someone from the other side of the building who they didn't know, who dressed in a white coat and had a clipboard and had a union meeting with these guys. And it resolved the situation. So we use props a lot. So one of the things we do sometimes do, if patients don't recognize medical staff, but they are reassured when they realize it's medical staff, is to use white coats or stethoscopes. We don't use the nurses' caps anymore because that's so long ago. Most of our patients don't remember that, although I remember that when I started my training. But we do use white coats, and we've dressed up it and done all sorts of things. They can be very helpful. And then sometimes we'll go along with the person. For example, as all of us will know, it's very common for people in long-term care to think they're either on a cruise ship or on a train. Sometimes, unfortunately, in a prison because of all the rooms in rows and so on. But, you know, I've often been the purser on cruise ships, doing my rounds at CDH on the medical floors. You know, I'm often going to speak to the captain to sort out a problem that's been happening at the night. You know, the staff of the night are making too much noise and they must concentrate on navigating the ship to the next port. And this is quite different to the way we orientate young people with primary psychotic disorders, where we actually don't collude with them. We try and use other strategies to orientate them to reality. in elderly with dementia who are misinterpreting their environments, it's much better to actually become part of their world and reassure them in that way.
You've hit the nail on the head in regard to misinterpreting their environment, which is, correct me if I'm wrong, a symptom of psychosis.
That's a very interesting question, and I often wonder about that myself. So the misinterpretation of the environment in people who have dementia isn't a primary psychotic symptom in the same way as somebody who has schizophrenia. So a psychotic symptom is when people are generating beliefs that are false. For example, if they're deluded, they're fixed, and in the face of corrective information, they're unable to correct their view. A hallucination is the perception of a stimulus in the absence of a stimulus. So there's nothing at all and someone hears a voice. A misinterpretation would be somebody sees a curtain move and thinks there's a person hiding behind the curtain. So that's a visual misinterpretation. So in the patients with dementia, sometimes it's because cognitively they're not able to interpret their environment. So it's as if they're doing a 1,000-piece puzzle and they've only got 250 pieces. So they're filling in the gaps. If I am Mrs. M and I lose my purse, but I'm an intelligent librarian, I know where I put it. It's not there now. So I then start to think, well, what could have happened to it? Well, maybe somebody took it, which is a very different process neurophysiologically to the generation of primary psychotic symptoms.
Ideation of reference, sure.
Yeah, and they've
what
done
I'm
some.
angling at, forgive me for, I don't need to step on you, I apologize.
No, carry
on. You probably are guessing where I want this to lead, and that is, when we look at the CI-HI data in terms of inappropriate use of antipsychotics in people with moderate to severe major neurocognitive disorders, it really occurs to me that we may be underdiagnosing psychosis as part of the clinical presentation and not mentioning psychosis, and therefore it appears that they are being inappropriately treated with major tranks.
Or the opposite may be true. Let me be the devil's advocate for a bit here. So one of my favorite positions to take. So if somebody is misinterpreting their environment based on those deficits, the cognitive deficits that they have, antipsychotics can't fix that. Antipsychotics can address the inferences that may arise from that. So if somebody's unable to interpret their environment and thinks they're on a cruise ship, no antipsychotic in the world is going to change that.
Right.
But if they think that they're in the mid-Atlantic and they're about to be bombed because they're in the Second World War,
right,
and they start hiding under their bed, then an antipsychotic could well be effective for them. So it's that inference. So psychosis is really when people are unable to experience reality, whatever that is. But it's highly contextual, and it depends on a person's ability to formulate cognitive assessments of the situation.
I think that's a very fine distinction. Thank you so much.
It's tricky. It is tricky. It's the same reason that people with intellectual disability are often over-medicated.
Thank you.
It's a good thing it's tricky because it keeps me in business. At least I've got a job. Yeah. Anything else before we let everyone go? I think we're at about time, Jessica.
Yeah, it looks like it. I don't see any more hands coming up or anyone unmuting. Thank you very much, Dr. Saunders. That was a wonderful talk. Thank you for coming.
It's a pleasure.
We really appreciate you spending some time with us tonight.
It's a pleasure. Take care, everybody.
Okay, thanks all.
Bye-bye.
Bye-bye.